Hi, welcome back to the channel. My name is Molly, and today at Live UTI Free, we're chatting with Dr. Roscoe Nelson about getting the right UTI treatment. If you're new to our channel, be sure to check out the description below as we've linked to other resources that you might find helpful. Lastly, if you enjoy these videos, think they're important, and want to support what we do, be sure to hit subscribe and tick the bell so you get notified when we post new videos. And other than that, we hope these videos provide the insights you need to take the next step on your UTI recovery journey. So joining us today is Dr. Roscoe Nelson. Firstly, thank you for taking the time to share your experience about recurrent UTIs in this Clinician Insights series.
Thank you. Thanks for having me. I'm excited to be here, and hopefully more people understand what's going on with these recurrent UTIs.
Yeah, definitely. So to start things off, could you please introduce yourself? Maybe tell us a little bit about your professional background, what led you to treating patients with recurrent UTIs?
Sure. So a little bit about my background. I grew up in Southern California. I did my undergraduate at Brigham Young University, went to med school back at UC San Diego, and then my residency at UC Davis. I've been in Arizona, practicing at Arizona urology specialist since the late 90s. So I've been around a little bit. And one of the things that, just a little background, one of the inventors of Elmeron was a guy named Lowell Parsons, and he was on staff at UC San Diego. And so there was exposure, but I realized it was a very controversial diagnosis. And this medication, it worked on some people, it didn't work on others. But I needed some research to try to impress people, get into urology. And they said, well, go with him. And they would have me put potassium citrate in people's bladders. Now, remember, this is in the early 90s. And some of these patients would literally come off the table in agony. It was horrible. I quit. I could not do this to these patients. And this was one of their diagnosis methods for what they called interstitial cystitis. So keep that in the background. I understood there were patients that had really bad pelvic pain. They thought they were UTIs. Their cultures were negative. And a lot of doctors would just blow it off and even get to the point where there were mental diagnoses. One other patient experience that really kind of shaped me. During my residency, we had a period where we had a residence clinic as a fourth-year resident. And there was a patient who, for 7 years, she was getting treated with antidepressants, all kinds of psych meds. And she got referred to me for blood in the urine. So I looked in her bladder, and it was ever since she had had a hysterectomy. I looked in her bladder, and there was a suture going from one side of the bladder to the other with a stone on it, jagged stone. Every time she urinated, it would grab onto her. And we took it out, and surprisingly, all her psych problems got better. Wow. And so these kind of things shape you, where you say, sometimes patients come in, all the dogma in the world as a physician isn't always right. We learn things, we change our mind. And so fast forward, probably 15 years ago, I had a guy come in, and he had a test with him, and it was it's what's now Microgen. It was called Pathogenius at the time. And for those who don't know, it's a next gen sequencing. And at this point, it was only PCR, polymerase chain reaction. And his urinalysis was negative, and his culture was negative, but his PCR test said he had E. coli. And I looked at that test and said, oh my gosh, this is the holy grail. Because for years, we would call that non-bacterial, non-inflammatory chronic prostatitis. So I immediately thought of all these women that were diagnosed with interstitial cystitis, and I started running this test, and 70–80% of them were bacteria with negative cultures, treated them with the right antibiotics, and their lives would get better. And so that's how I kind of got into the realm of this recurrent UTI. And so when someone comes in and says, well, I've had what feels like a UTI, but my doctors tell me I don't, I believe them. I listen to them. I'll run these tests. So that's kind of where I got started.
Yeah, no, I think one of our most popular articles as well is when UTI tests are negative, but they have the symptoms, and it's so frustrating for patients because it's like, where do you go from that? Definitely.
Well,
So
let me talk a little bit about that.
yeah.
The urine test that we use, a urine culture, is 70, 80 years old technology. They take a sterile swab, wipe it on agar, which is basically just a little petri dish of food for the bacteria, and they look at it at 48 hours. And there's so many things wrong with it. So certain bacteria will grow on it, but there's a lot of bacteria that don't grow on it. Their viruses won't grow, fungus won't grow on it. So if you have one bacteria like E. coli that grows really fast, sometimes it will overwhelm some of the slower, fastidious bacteria that takes either special tests. And so they've looked at DNA tests of people women with symptomatic UTIs, and about 50% are polymicrobial, meaning they'll have more than one bacteria. And they get treated for E. coli and they don't get better. And then pretty soon you treat them enough and E. coli quits growing out. They still have symptoms. But if you look at their DNA, it will be greater than 100,000 per milliliter DNA counts of multiple bacteria. So there are multiple reasons the regular standard culture are not sufficient. It's great for 21-year-old female comes in, first UTI, you do a culture, you treat it, she gets better. That's a fine, cheap test. But for your patients, the patients that are on your website, they need something more.
Yeah, definitely. So I know we've touched on this a little bit, but could you describe the types of tests that you use when examining a patient? So for recurrent or chronic UTI, and what clinical signs may guide these decisions?
Sure. So my starting point right now, I'll get a history, and I'll get a urinalysis and a culture. I want to see are there inflammatory cells, and I want to see what grows out on the culture. I do get useful information on that. My go-to test right now is Pathnostics. Pathnostics is a little bigger PCR test. I believe they have 46 or 48 different things they're looking for. But the one thing they do that I like is they have a pooled sensitivity test. So the bacteria, and the microorganisms can share information and share some of these genes to protect themselves. And so what Pathnostics does is it pulls them together and says, what is this collective? And we can talk about biofilms, later, but it looks at the collective and says, what is that collective sensitive to, and treats it. So I love the Pathnostics. I'll check a kidney function. I'm a urologist. I'm going to check an ultrasound of their kidneys, and I'm going to check. I'm going to look in their bladder and do a pelvic exam. There are things you have to watch out for. I will find patients with staghorn, which are big branch kidney stones that are holding bacteria that don't cause back pain, and they'll just be draining bacteria in the bladder. You got to clear that kind of thing out. Sometimes people have congenital problems, reflux, and you have to make sure there's not an anatomical problem. Suburethral diverticulum is if you don't look for that, you'll never find it. But once a year, I'll find a woman who has an abscess underneath the urethra that will fill with bacteria and then rupture into the urethra. They'll have painful intercourse, recurrent UTIs, and it's not really an embedded UTI. It needs to surgically be repaired. So I rule out, and I've had people diagnosed with interstitial cystitis that had urethral cancer. So I'm going to make sure it's not all the bad things. And then I'm going to engage in treating them. So that's my workup. It's going to be a urine culture. I do Pathnostics. I'll get a check kidney function, ultrasound, and do a cysto and an exam.
Interesting. So it sounds like there's quite a few factors which can increase the risk of UTIs, and that you look for as well when you're testing for UTIs as well.
Yeah, and there's some things you can't really test for. Every person has a different cellular makeup and areas for bacteria to attach to. You're different than me. You get some of these from your, genetically from your parents. And some people are more prone to having bacteria be able to attach to their urethra. Some people are less prone. And then the normal flora that we all have, the bacteria that are supposed to be on us, in us, that help us, some of them have more aggressive forms of those. Those are hard to test for, but those are things that you take into consideration, and you'll hear, yeah, my sister have recurrent UTIs, my mom had recurrent, or worse, I've had patients where their mom had their bladder removed because they diagnosed her with interstitial cystitis, and I think it was probably recurrent UTI.
So in terms of treatment, what is your typical treatment approach when you identify an infection?
So I'm going to go back just a teeny bit. When people come in with this pelvic pain, sometimes they're diagnosed with a lot of different things. They'll be diagnosed with interstitial cystitis. I believe there's probably 5 main things that may be going on. I think interstitial cystitis is real. I think it's very rare. That would be a defect in the lining of the bladder. There's probably some people that have that. There are some people that have pelvic floor dysfunction where just like you can get TMJ and give you a headache, your pelvic floor can spasm and can give you pelvic pain. A lot of women that are postmenopausal or perimenopausal, when they start losing that estrogen, it can make things uncomfortable. It makes them more prone to infection. That plays a role. There are people that just have food intolerances that irritate the bladder. But I think the majority of these symptoms are these chronic recurrent UTIs, biofilms, embedded UTIs. But all 5 of those things play on each other. If you have chronic cystitis, you're going to destroy your lining of your bladder just from recurrent infections. You're going to be more sensitive to food. If you're menopausal or perimenopausal, you're going to it changes the pH in the vagina. You're going to invite more of these nasty bacteria closer to your urethra and bladder. And then as these things happen, your pelvic floor starts to spasm. And so I can see where a doctor is going to go down one pathway, but all 5 of those things are interrelated. And so when I treat them, it depends how symptomatic they are. If it is I get a UTI 4 times a year, I take an antibiotic and I get better, I treat that person different than the patient who will tell me that, for 25 years, I've been having ongoing pain and all my tests are negative. I think the pathology that's going on is a little bit more involved in that second patient. But I'll typically focus on, I believe in antibiotics. I'm a doctor. I believe in antibiotics. I will typically do my pathognostics and treat that with 10 to 14 days. The short courses, 3 days antibiotics for the 21-year-old female with her first UTI, that's fine. For the person who's had 4 UTIs a year for 10 years, 3 days antibiotics probably is not going to treat that embedded UTI or biofilm. So I'm going to give them 10 to 14 days of a pathognostics-based antibiotic, and then I'll put them on macrobid. I like macrobid. It's an antibiotic you don't get resistant to. It doesn't kill bacteria. It starves them. It's called bacteriostatic as opposed to bactericidal. It's very weak. It doesn't penetrate the tissue very well. But nitrofurantoin is the other name for it. Nitrofurantoin, macrodantin, or macrobid, all the same thing. It is a good preventive antibiotic that can allow that bladder to heal and to slough off some of those the infected cells and regrow new lining. So I like macrobid. There's very rare pulmonary issues with macrobid. That's the main one. It doesn't cause yeast infections, doesn't cause bowel issues as often. So we go through those risks, but I'll put them on that daily for a period of time. I'll try to calm their bladder down. I'll use either an anticholinergic, I like Vesicare. Oxybutynin is a very nasty drug. Solifenacin, which is Vesicare, a little calmer, but if they're really symptomatic from the frequency urgency, I'll work on that. There are medicines like Urabel, Urogesic, Urel. They're all the same thing, just little different combinations that can give them a soothing just to get them comfortable. If it's a bad bacteria that has a lot of resistances, I'll use methanamine or Hiprex. That has to be used with vitamin C, and sometimes the vitamin C can be irritating, but it's more like an antiseptic.
Mm-hmm.
I'll give them here's a list of foods that might bother you. If they have a lot of pelvic floor spasm when I do the exam, I might have them see physical therapy to try to get that to relax. And if they're perimenopausal or menopausal, I'll try to get them on either vaginal estrogen, systemic. I'm more of a fan of bioidentical. My wife takes bioidentical testosterone, and the bodies are brilliant. The body will take that testosterone, if you understand the hormonal cascade, and convert that into estrogen. And so
Mm-hmm.
she gets bioidentical, very low doses. She converts it into her own estrogen. And so that's kind of my throw everything at it. I had a physician who was disabled. She was on disability because of this problem. And I threw everything. I put all 8 of those things at her. And she was working in 6 weeks. She was back working, and she feels normal now. We backed off. She's not on. I left one important thing out. We've taken off a bunch of those. She doesn't have to see PT, but her long-term, she's not on Vesicare. I think she's just on hormones. And then one of the mainstays, I like the natural stuff. The goal on these is get people into the proanthocyanidin, D-mannose type realm. And that is more of a maintenance. Those are 2 natural substances that proanthocyanidin is found in. It's kind of active ingredient in cranberry. You hear cranberries work.
Mm-hmm.
Proanthocyanidin is that active ingredient. If you just try to do cranberry or cranberry juice, you're going to get too much sugar. You're not going to get enough of that proanthocyanidin. And D-mannose is a type of sugar. Both of them work by, this is very simplified, but the bacteria basically have to attach. And these 2 products will grab onto those, and the pili, the stuff that grabs onto your tissue, and help prevent that attachment. So I'll get them on that with everything else, and then start backing off the antibiotics, backing off the Hiprex, backing off that. So long term, I'd like to see these people on a D-mannose PAC product to prevent.
I think it's a really important point, the fact that patients almost need to understand that it is an individualized approach, and it almost what helps one individual might not help another, and it is kind of finding that thing that works for you. I think that's really important.
That's a great point. Everybody's different.
Yeah.
I reached out to a company because I was frustrated with the cost of these natural products.
Yeah.
And you go on, and there's some really good ones out there. There's some really good ones that where people understand it, but everybody's selling something. I reached out to a company, and they created a MyPurology. It's called Purology, but the website's mypurology.com.
Mm-hmm.
And it's a PAC D-mannose combo. You take it twice a day. It's reasonably priced. And, where you're talking about, less than $1 a day.
Mm-hmm.
And it's good product. It's made in the US. I don't know if they ship it abroad, but it's a decent product. And, some of them I've go through all of them. Some of them have you at, hundreds of dollars a month getting good stuff. But I think this is, measured out, tested, secondary tested PAC.
So moving on, beyond treating the infection, do you have any tips on preventing future UTIs?
I sent you a link. It was a second link, and maybe put that with the video, because what I did, I felt bad for patients, and I don't want to, it's how many times you're told wipe front to back. I wipe front to back.
Yeah.
I pee after sex. I do this. I go through, I think I have 12 little videos, and if you sign up, I'm not selling anything, or it is, you sign up, you get a 2 to 3 minute video every day for 12 days. And it's like, okay, what about this? What about that? Things that you may not think of, the type of material in your panties, the type of underwear you wear, some certain habits that you might have, some sexual practices you might have, things you got to think about. And it's just 2-3 minutes. And if almost every person that goes through those will say, I thought about this, but I wasn't thinking about that.
Mm-hmm.
And then so for the young, healthy person, like if you came in my office, unless you've had your ovaries removed, your hormones are probably normal. I would treat it. I would get you on a D-mannose PAC product, and then I would have you come back and test it again. And I'd probably have you, do the physical things to prevent, stay on the D-mannose PAC for a period of time. If you have those bad bacteria as part of your natural, as part of your bacterial bio, what's in your normal flora, you're going to be prone to that potentially the rest of your life. You might be somebody that stays on those natural products forever.
Thank you. Yeah, that's interesting. I'll make sure to add the link in the description for that so people can have a look. And so finally, what is the best way for patients to reach out to your practice about recurrent and chronic UTIs?
So I have a website. It's called pdoc.com. It's PEEDOC.com. And on the front page, I talk about UTIs, but under conditions treated, I'll change my website all the time. But right now it's on the front page, and there's conditions treated recurrent UTIs. There is a request a call. But if you go on my website and it says request a call, it's actually an email goes directly to me, and I'll route you to the person that you need to get in. That's probably the best way to get a hold of me is through my website.
Okay, thank you. I'll add those details as well to the description. So thank you for talking to us today and providing these insights into the testing and treatment of recurrent UTIs. For anyone that's interested, I will add a link to the bottom of this video. But thank you very much.
Molly, thank you very much for having me.
Thanks so much for watching. I hope you found this video helpful. You're always welcome to reach out for more information about clinicians who specialise in recurrent and chronic UTI. Our contact is below in the description. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveuti3.com for other articles on recurrent UTI treatment options. Of course, if you like what we're doing on this channel, make sure to hit the subscribe button here on YouTube and tick the bell so you get notifications about future videos. Thank you so much for joining us for our Clinician Insight series. If you have suggestions for who we should interview next, be sure to give us a comment.